Hello friends, welcome to PGI discussion series number 2. The first question of today, features not defining severe sepsis. Options are in front of you. CVS, arterial systolic pressure more than 90 millimeter mercury for at least 1 hour. Renal urine output less than 0.5 ml. In the blood, platelet count less than 80,000, respiratory PaO2, FiO2 less than 250, or unexplained metabolic acidosis. The answer of this question is A. Now let's talk more about various things about sepsis. So before I discuss sepsis and SIRS, let's some basic term. We have a term called bacteremia that simply indicate presence of bacteria in the blood, and this you can prove by blood culture. Then we have septicemia. Septicemia means there is either microbe or its toxin are in the blood, and in septicemia if microbe is there we can get by culture, but if only toxins are there then culture will be negative. Then we have SIRS, that is systemic inflammatory response syndrome. First point, it could be infectious or it could be non-infectious in etiology. Now 2 or more of the following are required. First of all, fever or hypothermia. Second is tachypnea, tachycardia, leukocytosis or leukopenia, or band cells more than 10%. Okay. Now what is sepsis? This line is shifted, this line is from this place. Okay. Now sepsis, SIRS that have a proven or suspected microbial etiology is sepsis. Point to be noted, as I told you, it could be non-infectious in etiology also. Well, we talk more. Severe sepsis is also known as septic syndrome. So if there is evidence of one or more signs of organ dysfunction is what we call as severe sepsis. So in cardiovascular, if systolic BP is below 90 or mean arterial pressure below 70, and despite giving IV fluid they are not respond, that does not respond even to administration of IV fluid. Renal urine output less than 0.5 ml despite adequate hydration. FiO2 ratio is less than 250, or platelet count is less than 80,000, or an unexplained metabolic acidosis. Okay. Now what is septic shock? When systolic BP is below 90 or despite giving IV fluid for more than 1 hour. In other way around, we can say the point number 1 is almost like septic shock. Okay. And number 2, even we are giving vasopressor, but still mean arterial pressure does not go above 90 millimeter of mercury. Okay. Or we give vasopressor and then only you are able to maintain pressure above 90, but that means the moment you withdraw the vasopressor, again the BP falls back below 90 millimeter of mercury of systole. So these indicate septic shock. Okay. So a quick recap of last minute revision point about pneumonia as well as sepsis. Okay. The most common cause of nosocomial pneumonia is gram negative Enterobacteriaceae. Tubular breathing is heard in consolidation. Curve 65 is for pneumonia to assess its severity. Then cavitative lesions are seen in Staphylococcus pneumonia, so-called pneumatocele. Chocolate color sputum is seen in Klebsiella pneumonia. Hemolytic anemia is seen in Mycoplasma pneumonia. And we give pneumocystic carni prophylaxis when CD4 count is below 200 per ml. Pneumocystic carni is best diagnosed by BAL. Commonest sign of aspiration pneumonia is tachypnea. Most common cause of empyema is bacterial pneumonia. Hypotension is not a feature of SARS, it is a feature of septic shock, and endotoxic shock is initiated by endothelium damage or injury. Let us talk about question number 2. Transudative pleural effusion is seen in all except myxedema, nephrotics, CP, yellow nail syndrome, and intra-abdominal abscess. The answer of this question is yellow nail syndrome and intra-abdominal abscess. In these two conditions you get exudate. Now let us learn more in depth about pleural effusion. It is the collection of fluid in the pleural space, and effusion we divide into two categories, transudate and exudate. In transudate the fluid protein is less than 3 gram per cent, in exudate it is more than 3 gram per cent, and sometime blood may be there, so-called HICA and so-called hemothorax, but pus may be there, be empyema, or chyle may be there, so-called chylothorax. That means additional feature like blood, chyle or may be there, or pus may be there. Well, if both air and fluid is there, both blood and air is there, then we call as hemopneumothorax. If only air and fluid is there, then we call as hydropneumothorax. If blood is there, then we call as hemopneumothorax. Now here is the photograph. This is, you can see, typically photograph of pleural effusion. It is rising, so-called Alice curve. But if you are getting a flat line like this, that indicate hydropneumothorax. Now what are the causes of transudate? Transudate we see in increased venous pressure like cardiac failure, constrictive pericarditis, and fluid overload. Hypoproteinemia like cirrhosis, nephrotic syndrome, or malabsorption or malnutrition. Hypothyroid again has transudate. Now exudate, the causes are bacterial pneumonia, tuberculosis, pulmonary infarction, rheumatoid arthritis, lung cancer, SLE lymphoma, mesothelioma, Meek syndrome, they all lead to exudate. Now whenever we get a case of pleural effusion, the first investigation is always chest X-ray, so-called the best initial test, but later on we do the pleural fluid examination, and if you have to confirm it is a transudate or exudate, the feature of exudate are pleural fluid protein, serum protein fluid ratio is more than 0.5, pleural fluid LDH or serum LDH ratio is more than 0.6, or the pleural fluid LDH is more than 2/3 of the upper limit of the normal LDH. They are the feature of exudate. So let us have a quick recap of various point about last minute revision point of not only pleural effusion but pneumothorax also. So primary spontaneous pneumothorax is common in young male, or young age, not male, young age, both male female. Exudative pleural effusion occur in bronchogenic carcinoma. Left sided effusion is seen in pancreatitis, RA, esophageal rupture. In tubercular pleural effusion, glucose level is normal or mildly reduced. This question comes almost every year. Decreased glucose is seen in typically rheumatoid arthritis. They are very important question. Okay. High amylase level is seen in malignancy. Cholesterol crystal in effusion is seen in myxedema or hypothyroid. In hydropneumothorax, we have a horizontal fluid level and succussion splashes there. In the adult patient with pleural effusion, the most common appropriate site for tapping is by inserting a needle in the 7th intercostal space in the mid axillary line. So they are some of the very important last minute revision point taken from our book of medicine essence. Now let us talk about true statement about psoriatic arthritis are all except DIP is involved, frequent axial skeleton involvement, dactylitis, steroid are effective, or aortic wall insufficiency can occur. The answer is systemic steroids are very effective. That means they are not effective because he is asking about the except. Okay. So let us learn more about psoriatic arthritis. So it is again a seronegative inflammatory arthritis, and patient has change in the nail as well as skin also. And since it is a part of seronegative arthritis, so let us see what are the other types of arthritis which are a part of seronegative. The other are ankylosing spondylitis, Retter's disease, juvenile rheumatoid arthritis, arthritis occurring in inflammatory bowel disease. Now what are the features common to all these? All of them are seronegative, that means rheumatoid factor is negative. All these are HLA B27 positive. In all the cases sacroiliitis occurs, that means axial skeleton involvement is a feature. In these patients enthesis can occur. Okay. Now let us see what are the extra things which happen in psoriatic arthritis. Asymmetrical oligoarthritis, sacroiliitis or spondylitis I discuss, and sometime uncommonly patient may have even symmetrical seronegative arthritis just resembling like rheumatoid arthritis, but in this patient rheumatoid factor is negative, in rheumatoid arthritis rheumatoid factor is positive. DIP involvement is, I think this is one of the most important question, and this one point we differentiate from RA because in RA DIP is not involved. And one more thing, in this patient typically in the advanced stages you get arthritis mutilans, on an X-ray you get penicillin cup appearance. I will show you this photograph just now. One more feature what we get in psoriatic is psoriatic arthropathy, the finger becomes like sausage. Just see, normally finger have like this, okay, but here the finger become like a cylinder. You can see cylindrical picture, so called sausage finger, and of course DIP is involved. The diagnosis is bit easier because patient may have associated nail changes or skin changes, so called silvery scale. Now what are the articular feature we have? Silvery scales are there, nail changes are pitting, onycholysis, hyperketosis, sausage shaped digit, and hand joints involved are PIP, DIP, MCP and wrist. Practically all hand joints are involved. The best initial test is you take X-ray of the joint, we show penicillin cup appearance, ESR is raised, uric acid are typically raised because of skin lesions. This is what I was talking to you. Beautiful photograph, pencil in cup appearance. Okay, this is normal, this is the diagrammatic, and this is the photograph. You can see pencil in cup appearance deformity is seen in psoriatic arthritis. Now, what treatment we give? Analgesic, we can give TNF alpha neutralizing drug like infliximab, etanercept. Now, certain newer drugs have recently been introduced. Ustekinumab, which is a interleukin 23, interleukin 12 antagonist. Then again secukinumab and brodalumab, they are anti-interleukin 17. Aprilimas, which is a oral phosphodiesterase 4 inhibitor, can be used. Then sulfasalazine can be used. Of course, this we use for RA also. Chloroquine and hydroxychloroquine are used. This we use in RA also. This we use in SLE, mainly SLE we use, and of course we use in RA also. Retinoid we can use. Methotrexate can be given, but not a very popular drug. But steroids are definitely not given. Even methotrexate is not a #1 drug in this. It's just a last resort. So the best answer is steroids are not given in these patients. Now, question number 4. False about Prinz's metal angina. Smoking is a risk factor. Coronary artery may be normal in anatomy. Attack tend to occur between midnight and 8 a.m. ST segment depression is more common, and acetylcholine induced vasoconstriction is a central mechanism. The answer is D, because it is the ST segment elevation occurs, not the ST segment depression. Let us learn more about Prinz's metal angina, also known as variant angina, also known as vasospastic angina. Why? This is the normal coronary artery. No normal endothelium and patent lumen is there. Now, what happens in stable angina? You get a plaque. Now, what happens in vasospastic? Artery is normal. There is no, there may not be any plaque, but the artery go into intense vasoconstriction. So the clinical feature of Prinz's metal angina are, it is more in younger patient below 50 years. Smoking is a very important predisposing factor. Other risk factors in like diabetes, hyperlipidemia, hypertension may not play much role in this, but smoking is the most important in this, the precipitation of Prinz's metal angina. Patient has recurrent chest discomfort, occur at rest or during sleep, and usually spontaneously resolve within 15 minutes. How we diagnose? You go for ambulatory ECG, you get ST segment elevation, and if you go for coronary angiography, the coronary artery is normal, there is no plaque. In the treatment, we can give calcium channel blocker like diltiazem. Now, a word about 3 calcium channel blocker. Diltiazem has particular action in coronary artery and they dilate. Verapamil has primarily used for arrhythmias, and nifedipine is the primary drug used for treatment of hypertension. So they are the 3 primary calcium channel blocker, but they have a different role to play. Now, sublingual nitrate is always the drug of choice in acute case, and it is usually abortive. Calcium channel blocker is preventive, and beta blocker are contraindicated in this. But remember, beta blocker are one of the drug of choice for stable angina, but it is contraindicated in these patients. Now, what finding you get in ECG? This is normal ECG, and in case of principal angina, you can see ST segment elevation is there, and they tend to return to normal level after giving nitroglycerin. I told you nitroglycerin or nitrate given is abortive. That means it is really going to dilate the arteriole, so the attack will be abolished. Now the question number 5, true about COPD, FEV1 less than 30, FEV1 FAC ratio less than 0.7, reduce residual volume, increase total lung volume, hypoxia with hypercapnia. The answer of this question is A, B, D and E. That means C is wrong, rest all are correct. Let us learn in great detail about chronic bronchitis. First of all, you diagnose this by history. Patient has a cough, sputum production for more than 3 consecutive years, 3 consecutive months for 2 consecutive years. So there are 3 important bacteria which are responsible for this: H. influenzae, strep pneumonia and Moraxella catarrhalis. Okay. So you can have a mnemonic PIC. PIC is the mnemonic to remember. Point to be noted, Staphylococcus is not an important bacteria in this. And what happened in COPD or chronic bronchitis? FEV1 is highly reduced, but the first abnormality is to go down is maximum mid expiratory flow rate, residual volume is increased and normal diffusion capacity. Remember, in all obstructive airway disease the diffusion capacity is normal except emphysema. In emphysema the diffusion capacity is reduced. Now in these chronic bronchitis patient, Reed index, this is increased. This is a very important question. What is this? This is the supposed bronchial wall thickness, and here is the goblet cell, so called mucus secreting gland. Suppose the size of this gland is 1 millimeter and the thickness is 4 millimeter. Thickness of the bronchial wall is 4 millimeter. How much is the ratio? 0.25. And in chronic bronchitis, one of the classical pathology is this mucus secreting gland, they enlarge. Suppose now this has gone to 2 millimeter. The bronchial wall remain 4. The ratio has gone to 0.5. The Reed index increases in chronic bronchitis. Now these patients are cyanose, that is why they are known as blue bloaters, and typically they have a type 2 failure, hypoxia with hypercapnia, and the respiratory center are relatively insensitive to CO2, and ultimately they have to depend on the supplemental oxygen. The 2 classical signs that we see in cases of COPD, of course this I am talking to including emphysema also. One is Hoover sign and other is tripod sign. They are seen, of course they are more common in emphysema, but a very frequently asked question seen in COPD. Now what are the complications which can occur in a case of COPD? The complications are acute exacerbation. This is especially precipitated by some infection in case of chronic bronchitis. Polycythemia occur in chronic bronchitis because they have a deep cyanosis, in contrast to emphysema where they have a pink puffer. That means they do not have much hypoxia or much hypercapnia. Respiratory failure type 2 is very common in chronic bronchitis. Cor pulmonale can occur in either the 2. Pneumothorax may occur in emphysema because they have bullae, and pulmonary arterial hypertension occur in chronic bronchitis. Now let us have a quick recap of the last minute revision point taken from Medicine Essence. Reed index is used to diagnose a case of chronic bronchitis, or other you should say Reed index is a feature of chronic bronchitis. It is lung function in emphysema, the diffusion is reduced, but in chronic bronchitis it is normal. Weight loss is seen in emphysema rather, and in chronic bronchitis they are usually obese. Pneumothorax occur in emphysema, polycythemia occur in chronic bronchitis. Gold criteria is used to assess the severity of a case of COPD. So in addition to this discussion, we have many more things for you. For my undergraduate friends, we have a UG test series. It's an online test series with explanatory answer. To all my friends who are writing PG entrance, we have a grand test, subject test, and our tests are being made by the expert. We give explanatory answer and we give video discussion also. No one else does this. We have a champion live test where you have to go to computer lab to have an actual feel of the test. We are also launching USMLE step 2. All of you must watch this lecture. You will be amazed to see this. Your all acid base concept will be totally clear. It's a free of cost. You must see. And our books, and again I am very happy to inform you that in the AIMS PG exam May 2018, 81 question came from 200 came from our LMRPs which we have been discussing, and 20 topics were there in the last 2 weeks strategy. Okay, and I hope you are receiving my LMRPs, or those who have our books. Our books have more than 7,000 LMRPs, and if you know this much LMRPs, you are bound to be in the list of successful candidates. You can get this book from our website or Amazon Flipkart also. Okay, I have recorded many lectures on medicine. You can see at our YouTube channels, and this is the mini Harrison for undergraduate, and Essence is for intern and post intern. Whatever LMRP I told you are all from this book. Okay, and still you want to get connected with me, this is my personal WhatsApp number. Send me the details what I asked you. I'll be sending you lot of updates, and once we finish PGI series, then I'll be discussing JIPMER question also, right. Thank you very much for watching this video. Please give me useful feedback. Thank you.